Welcome to EPoster 11 Roundup. My name's Mukherjee. I'm a urologist from Mid-Cheshire Hospitals in Crewe. I'm the training programme director for the MERS rotation, and I'm co-chairing with my colleague and friend, John McCabe, my predecessor as training programme director and urological surgeon from Wiston Hospital. John also sits on the SAC. So we've got 12 posters to take you through in this session. They're very exciting and varied. And it really is an honour to co-chair this session. John, I'm going to kickstart with the first poster, if that's okay.
Great.
The first poster is by Subrata Mukherjee, a great surname. He's looking at the referral to treatment pathway and clinicians' awareness, how small changes can make in practice can make a big difference. And I think this is an excellent poster. It really highlights the importance of the RTT coding and accuracy in the trust performance. A questionnaire was designed to look at potentially 10 different clinical scenarios, and the 17 urologists, generally consultant level, were asked to mark the outcome. And in the first round, often multiple outcomes were selected, and inappropriate outcomes. In the second cycle, the accuracy was 100%, resulting in a reduction in potential breaches. As a result of this change in practice, a new simplified coding sheet was developed, resulting in 20% reduction in breaches. So this was an excellent way of educating clinicians in the RTT pathway. On the graphs, you can see in the pie charts, there's a RAG system, red, amber, green. It would have been useful to find out who decided what the colour code for the different answers were. So green was the most appropriate answer, red was an inappropriate answer. And maybe an overall summary results table would have been helpful as well. But overall, I felt this was an excellent poster that resulted in clinical change.
Yeah, very much so. I think it was. I think it's a really important message. And I think it's something that's really quite important for trainees, to get an appreciation of it. So, the targets is a mystery world really until you become often get to that consultant level. I suppose the big question is also, did it change the experience for patients? Did it affect, whether is the patient going to be treated in a more timely way because of the compliance with the target? And that's a different piece of work completely in itself, isn't it, in terms of clinical priority and the patient experience.
It'd be interesting to ask some of those questions to a general panel, because I looked at them and I had a few thoughts myself, to be honest. But it goes to show there is a bit of grayness in how to manage the RTT.
Absolutely, an interesting one. So we'll go on to the next presentation now. And this was This is from the UCL. Sorry, this is from Mr. Keskin and senior author Hash Ahmed, meeting the 28-day faster diagnosis standard, data from the rapid study, and comparing that to a standard pathway. So interestingly, the 28-day standard for cancer diagnostics is pretty much upon us now, and this will put extra pressure on cancer pathways. And what this study is looking at is the use of really immediate MRI arranged at the time of referral, so that when the patient's first seen, an MRI has taken place, and the consultation, the MRI can be reviewed and a decision made to biopsy, and how that model really leads to a far greater compliance in achieving that 28-day faster diagnostic standard. I think that the data speaks for itself. It's a big series. It's it's high quality data, and the challenge, I suppose, based on this data is for every smaller unit to be able to roll this type of service out. The huge pressure this puts on radiological services, we could talk about at length, but certainly I think most people would now conclude that this is the way to go, and critically also reducing the number of unnecessary biopsies in those patients with lower risk MRI scans. I don't know if you've got any comments on that, Rono.
Yeah, I thought it was a great study as well. Very topical, and good numbers, good power there as well. The standard pathway obviously was a control and a very different cohort of patients. The average age was 80 versus 66. The PSA was slightly higher. But yeah, it just goes to show. I was impressed personally at how they managed to do a same-day MRI and proceed to a potential transperineal biopsy and a local anaesthetic in 58% of patients. I think that's a great system, and well done for these guys to arrange that.
Absolutely, and I think it's just you, and I suppose in particular in this change of, the change of where we're having to work, less attended, patients attend on less occasions in this sort of peri and post-COVID world. These one-stop and rapid pathways are absolutely essential, especially when we're trying to catch up with huge amounts of backlogs. Yeah,
100%. So the next slide, post number 3, the 5-year outcomes of suspected prostate cancer referral seen in a nurse-led clinic by Wayment et al. From Wolverhampton. So again, the concept of one-stop clinics and streamlining cancer diagnostic services, a really good study. So it highlighted the increase in referrals of prostate cancer by 39% between 2014 and 2018. And it looked at the ANP-led clinic over 5 years with 2 aims. One was to review the patients that were discharged, and the other aim was to look at the outcomes of the PIRADS-2 patients. 2,393 patients were seen in the clinic. 953 met the inclusion criteria for the audit. I had no history of prostate cancer or no previous biopsy. 29% of patients had a normal PSA on repeat and were therefore discharged. 38% were discharged with the baseline multiparametric MRI scan being normal on the background of a normal PSA. Also, no family history or risk factors for prostate cancer. And only 6 patients in that whole cohort, 2%, less than 2%, had developed a clinically significant prostate cancer subsequently over the next 22 months, and that was defined as Gleason 3+4 and above. Interesting, in the 953 patients, 10% had a normal MRI scan, and I would say normal PIRADS-2 or less, and have had no cancer since then. 90 patients, less than 10%, were discharged for GP PSA monitoring, but this did not occur, and that's a bit of a concern as well. So the conclusion is a nurse-led clinic is effective and safe based on 2 PSA tests and an MRI scan with a PIRADS score of 2 or less. These guys are safe for discharge based on that, the number who did develop, the small number who developed prostate cancer thereafter. A very useful study and a very well presented poster as well, John.
Yeah, no, absolutely. I think it fits nicely with the last paper, really. The pressures of getting patients through in a timely way in a 28-day pathway clearly requires an extended workforce, and a nurse-led model like this is certainly very much part of that essential offering. I concur with you about the 90 patients that were discharged back to primary care with advice for follow-up PSAs, and that's the danger of this, is that it's fail-safes and working out adequate lines of communication, isn't it? And really, I suppose it's engaging the patients to take control of this as well. It's not going to be an easy thing for the GP necessarily to follow up these PSAs, and a lesson from this perhaps is when you're discharging these patients back to the community, is very, very much for them to take ownership of this perhaps as well. Yeah,
I agree. So a good study.
We're taking on to the next one. So this one again, it's we seem to link in now. So we move from the nurse specialist onto the physician associate. So this is the role of the physician associate in urology, an experience from a tertiary centre in the UK by Williams et al. From Norfolk. And I think this is a nice piece of work that really just educates those of us that aren't yet that familiar about the role of the physician associate. Some units we're living, embrace them and taking them on board within the urology departments, and some probably not yet. And the paper's telling us really the day-to-day activity of those physician associates, and also that more importantly, really quite nice was the feedback around the work that they did. And the work is that a lot of the work is, as we might expect, core ward and diagnostic work, and also assisting in theatre, which in the era of limited trainees and limited doctors of all grades, to have this extra very well qualified workforce contributing in that continuity to the regular workforce is essential. But I was really heartened by the MSF that these physician associates shared, showing that that the feedback was really quite strong. So yeah, a nice paper. Any thoughts there, Ronnie?
Yeah, absolutely. I mean, we've got a physician associate as well, and the trust lead is one of my colleagues, which is great. So yeah, this is definitely part of the future. We've got to embrace this, and it's nice to see this type of study coming through. So well done, Rhys Williams, for collecting that data. I was impressed with over 500 flexible cystoscopies. Most of them were unsupervised, which is great. I was very impressed with the MSF, John, as you said, good to outstanding. With no concerns. 16% were unable to comment. I'm not sure why they were unable to comment, but overall it was a very positive.
Must have asked the wrong people.
Well, that's right. Yeah, generally with an MSF, you ask the right people, isn't it? And 36 LA transperineal biopsies were observed. 17 were carried out supervised. So I guess the next phase of the study that I'm sure these guys will present will be that data, and also more data on the on-call, the ward work, and the clinics. So it's a very good early study, but I'm looking forward to seeing more from these guys.
Absolutely.
Next presentation is I like this one. A UK urology training. How many procedures are required to gain competency in core urological procedures by Veggers et al., who's a Northwest Core trainee. A few star names there: Mr. Morley, former head of SAC, and Luke Forster, the former head of BSOT. So this is a good study, and it basically looks at the fact that the new curriculum is going to be more competency-based as of September of next year, quite rightly, versus a numbers-based game. But the question asked was, do indicative numbers correlate with the level of competence? And the methodology was to review the e-logbooks of trainees and the WBAs 5 months pre and post CCT in May of 2019. Interestingly, for the level 4 procedures, this is something, John, you and me have debated quite a lot on our ARCP panels, and the variety. But for the level 4 procedures, the mean numbers achieved were 146% of the indicative number, which is good news. Interestingly, in this cohort, only 84% achieved the TURP indicative number, which is normally one of the first to come along. So I guess there must be some regional variation, of course. Urodynamics and scrotal procedures were just on the 100% mark, which goes to show they can be difficult to get. For the level 1 to 2 procedures, the average was 99%, only 40% for PCNLs, and then 235% for conduits, so obviously a very conduit-heavy region. So generally, the numbers are about right when you average it all out. I think is the take-home message. But there is a wide range. For example, uteroscopy, they achieved their competencies anything between 0.3% of the recommended indicative number and 9.8 times as many. So there's a big variation. So in conclusion, indicative numbers were seen to be a reasonable guide to competence, but there is a wide range of variation. And I think it supports the fact that in the new curriculum, the competency-based system is probably going to be more accurate. But I really like this study. John, what do you think?
Yeah, no, absolutely. And it sort of steers in that direction of a competency-based training. But I suppose the question beyond this study that perhaps it raises is, how assessment and definition of competency and how we're defining that. There's such clearly a broad gulf in trainees and when they're being defined as competent, and that a lot of that will come down to individual trainees developing and progressing at different rates. But some of it might be as to between the trainee and the trainer defining them as level 4 competent and how they've got to that point, and so how we standardize that going forward, and how we is a gigantic, a huge task, and whether that can ever be truly achieved. But that's something maybe to talk on in the future.
Yeah, I agree. And I guess that's the idea behind the multiple consultant report. But then, there's more to come.
Yeah, absolutely. Standardizing things.
Yeah, more clarity next year. Yeah, but a good study.
Poster number 6 was by Nicholas Bullock et al., looking at establishing a national cadaveric emergency urology course to increase trainee preparedness for independent on-call practice in the United Kingdom. So this is from 2 centres, from Cardiff and from Adam Brooks, and it's based around the development in recent years of cadaveric emergency urology training, which actually myself and you, Ronno, were part of in its earliest phase a few years ago when we ran some courses for BAUS. And the challenge has always been sustaining those courses in centres and ensuring that trainees can gain access to what is an expensive and time-consuming course. So this paper has looked at the quality of the experience gained by the trainees, and the idea of the emergency courses for them to simulate experiences in things that maybe they won't be, the trainees struggle during the time to get regular exposure to, because of the relatively rare, so many of these urological emergencies are relatively rare events, and therefore during your period of training you won't be exposed to them regularly, but you will be required to have a good degree of competency in them when you are a core practicing urologist. So the rationale for the cadaveric simulation is that this, it's probably the most reliable form of simulating a lot of these emergency procedures. I think that the paper here is really has given further it's given us further evidence to validate that, really, with having been involved in the initial validation of this cadaveric work. I think this just goes on to reinforce that. And in particular, it shows that a standardization of the curriculum between the 2 sites, and if this is rolled on to more sites across the country, having a unified standardized curriculum for the course, is beneficial, and it will ensure that we'll, again, when we're looking at competency, we've got some benchmarks to assess each trainee against to ensure that they're getting towards these competencies in what can be quite difficult. But a really nice and really precise paper. I was very impressed with it.
Yeah, I agree, and of course I was honoured to be involved in the course that you set up. I mean, you led the way with cadaveric courses certainly in the north, and they were BAUS accredited as well. They were great courses, and I think this paper kind of follows on and says, look, this is the way forward. And as you said, if we can standardise that type and that syllabus, that's really important. And obviously the results were very clear: minimal exposure before the course. But all candidates in their linear scores were increased after the course. I thought it was quite good to see 9% of the applicants were consultants. I think that's great, to be honest.
Yeah, and I think that's a real role for this type of training, isn't it? Is especially for the vast majority of consultants who are practicing in sort of core general urology now, and aren't regularly reconstructing the urinary tracts to get a bit of cadaveric training like this. Yeah. And that's what drove me to be involved in this in the first place, and probably you as well.
Yes.
It gives us that confidence as endo-urologists that when things go wrong, we've got a little bit of a clue still.
Absolutely. The pulse has gone up there just even thinking about it. So moving on to the next slide. Urology bootcamp for medical students, improving the knowledge and skills of tomorrow's doctors. An excellent study and an excellent idea. I don't know if it was in any way they're related to the bootcamp, John, that we're involved in with the guys at Leeds, but this is from Ricky Ellis in Derby, and it highlighted the sporadic nature of urological conditions, teaching of urological conditions in medical school, and trying to kind of address that, and procedures as well, such as catheterization and examination of genitalia. This is a one-day course meeting the kind of BAUS undergraduate curriculum, mixture of lectures, small group teaching and clinical skills workshops, led by SPRs and clinical nurse educators. They had a control group of medical students sitting the finals versus those that went into the boot camp, roughly of 20 each. There was definitely a difference. So we need to see more of this around the country, I think, for sure, so that our foundation year doctors and beyond are better educated in urology. Interesting, yeah, 50% felt that the knowledge was good, 17% felt the knowledge was excellent, 67% felt better prepared for the exam, 56% moderately confident about the exam, 29% still do not feel that they were prepared enough. So it's possible that this, for sure, it helps and prepares guys for their exams and foundation years. And maybe one day isn't enough, because I thought it'd be higher than those numbers. To be honest, I thought 50% wasn't great. So maybe they could consider a 2-day course, but certainly something that we should think about.
Yeah, and I mean, it helped. I think it reinforces the need and the voice that's grown through BAUS for ensuring that there is a greater presence of urology in the undergraduate curriculum, and this type of data reinforces the need for that. But this was a really great effort, wasn't it, in terms of building confidence, and from a patient safety point of view, it's fantastic that junior trainees will be coming in with that little bit more exposure and confidence in dealing with these situations.
Yeah, well done these guys for doing that.
Absolutely.
Good study.
So the next, poster was investigating the effectiveness of shared medical appointments for prostate cancer survivors after robotic surgical treatment, and this was from TUES et al. From Barts and Guy's and St Thomas's. So this was again a nice piece of work. It's trying to streamline that complicated follow-up for these patients who have undergone radical prostatectomy, in terms of their a lot of the symptomatic follow-up requirements, such as andrological follow-up, and it was looking at sort of the shared group appointments, with the shared medical appointments, which I think certainly have a great role in patient education, and in terms of engaging the patient, educating the patient clearly, giving them a consistent message, and making sure they've got the right access to resources. I think there's two sides to it, though, isn't there? There's also that, is it depersonalizing care? And that could be an argument against this approach. And I think this paper is looking at that, and looking at different groups, and in particular looking at culturally experience as well. There was highlighted in the paper that there was more anxieties about this approach amongst some minority ethnicity groups, and that needs probably some further work to explore culturally, why that is, and why patients might, from those groups may feel a little bit more uncomfortable about this shared experience. But all in all, I think it certainly shows us that there's a role for it, but that it's there isn't a one rule fits all, and amidst all of this, each one of these individuals is a patient, and we've got to ensure that they get the best possible experience. Whilst we're trying to whilst we're improving efficiencies and reducing clinic appointments, just my anxiety about a lot of these things at times is that we don't forget that there is each patient is an individual, and to bear that in mind. I don't know what your thoughts are there, Ronnie.
Yeah, I agree. That I was actually surprised at this. I've got no experience of shared medical appointments, but I thought it was interesting they wanted to address that, and you can see the driver for that in terms of reducing clinic appointments. Men discussing the erectile dysfunction and incontinence in a group, 222 out of 223 were satisfied with that, which I was surprised at. So that's very interesting. I think maybe it's a case of guys like to know that they're not the only person who's leaking, etc. And the numbers were really good. 218 felt comfortable managing and talking about their side effects, and talking about it in a group. The BAME population were slightly less so, and that's interesting that they've highlighted a sub-analysis based on cultural backgrounds. 17% rather too much information was given, and they'd rather had more appointments, even if it went up to 3 extra appointments. So that's interesting to know that, so you can individualize what goes down this route. So, but a good study that was a bit of an eye opener for me.
Yeah, no, absolutely. Okay, we'll look at the next page.
Next slide is Chairport, same-day discharge innovation permitting high flow during times of bed occupancy. So they are very relevant for the COVID era. This is by Papworth et al. From Bath. Elective post-ops, discharge on the same day, looking at reducing length of stay, and is one of the quality indicators for GIRFT. So if patients were deemed suitable, they were managed post-operatively in a chair port, which is a nurse-led 9-chaired unit, ambulatory and ring-fenced from inpatient and emergency care. Generally, the criteria, I guess, included BMIs less than 40, obviously, and 93% were low ASA 1 and 2 patients. It's a review over 22 months between 2017 and 2019. Over 1,000 patients, high number, 334 were transperineal biopsies, 141 circs. I was interested that 88 post-uteroscopy patients were put through this. I think that was really good to see. And of those patients, only 3 were readmitted for other related issues that they didn't feel was because of their post-operative care over a 30-day period. So that was excellent to hear. Urocystoscopies, prenoscrotal work, and also five TURPs were managed in this way as well. So that's interesting, and it is a shame that we can't discuss this further in the old-fashioned way, but I'd like to know more about that. So yeah, I think they had 10 to 25 patients a day, 82% were general anaesthetic, an age range between 16 and 93, mean op time was low, 41 minutes, and yeah, 35% of all urological cases between 2018 and 19 went down this pathway. So I guess it's only limited by the number of chairs they have and the number of staff. But the feedback's excellent, and it's certainly something that I think we can expand around the country, and certainly in Bath, they probably want to get more chair ports in. It makes sense.
Absolutely, and I suppose, and the case mix, you probably since this time now we're rapidly moving on to that 32% that constituted prostate biopsy is probably all increasingly moving out to a local anaesthetic outpatient scenario, so that that frees up a huge amount it just demonstrates how much capacity you're freeing up in day case units. But we have a similar setup ourselves, and it demonstrates safety, doesn't it?
Yeah,
it's reassuring. There's TURPs and there's TURPs, I suspect.
Yes. And I'm thinking maybe Urolift would be ideally suited to that.
Absolutely, and resumes and those sorts of things. Yeah. So we'll go on to poster number 10, which is variations in clinical commission of circumcision surgery in England. Are there equal standards of care? And this was by Clark et al. from Guy's and St Thomas's. And yeah, again, this a really interesting study which just highlights the absolute inconsistencies across the country, across CCGs in the commissioning rules for circumcision and foreskin surgery. We as urologists would accept the vast majority of those indications, those clinical indications as sensible and good clinical reasons for proceeding to do this surgery in an informed manner. But there is, it makes it very difficult across the country, both for general practitioners and for secondary care, when there's when guidance is so inconsistent, and ultimately that makes it can be clearly very difficult then for patients to access the care in an appropriate way as well. That's something, there is clear BAUS guidance, and the message here is that to try and bring those those guidelines together, and the danger of of care by postcode here, isn't there, if we're not careful. I don't know what your thoughts are on that, Ronnie.
Yeah, absolutely. A very good question. I think these are procedures of low clinical value. I think I mentioned there was an RCS review saying that there is this variation. So it's good that these guys are looking at circumcision in particular as a kind of a landmark indicator procedure for urology. Yeah, I was surprised that only 29% actually had guidelines. I think it was 29% based on the BAUS and RCS indications, which goes to show. I thought there was some discrepancies, and it's a shame that the author isn't here to talk about this poster. But in the table, I thought there were a couple of discrepancies in the numbers, but it's probably my interpretation of it. But nevertheless, the take-home message is that there is a postcode lottery in terms of some of these cases getting funded.
Okay.
Next
poster number 11. Yeah.
11. This is the national implementation of an evidence-based, stakeholder-driven national quality improvement programme, and it's an update by Wilson et al. From King's College London and Barts. It recognises that quality improvement is essential in healthcare, but its implementation is fragmented in the UK. And in 2016, these guys developed something called the EQUIP Education in Quality Improvement Programme, aimed at urology trainees. And this looked at how they implement this through a theory of change method involving the stakeholders. And it talks about the development phase, there's 3 phases: review phase and refinement phase. And the conclusion was that this, quite rightly, should be driven by BAUS nationally and maybe with the appointment of regional quality improvement champions. It looks good. It'd be nice, again, if the author was here. It's a shame that we can't flesh it out a bit and talk about this, but it's obviously a very good initiative.
Yeah, no, absolutely. I think it's highlighting a big initiative, isn't it? And I suppose the importance for me is a structure of giving direction to make sure that the quality improvement is used in the right way, and there's real direction for trainees for all of us in terms of making sure those projects give value for the time and investment and money involved in them.
Yeah. Good study. So what's our last poster now? Poster number 12.
And that's the real world financial benefits of outpatient bladder cancer management using a dual diode laser. And which is certainly one that interests me. We've just invested in this technology and started offering this service back in our unit. And this comes from the paper here is from Syed et al. from 3 sites across London, Ashford, Northwick, and Imperial College. And I think, again, it's very apt for the current situation we're in now, as we're looking to we're looking to, in particular in this COVID age, looking to make sure we minimise the number of patients coming through day case and inpatient pathways. And this paper demonstrates a real cost-effective alternative for managing superficial bladder tumours in the outpatient settings. It gives us a lot of efficiency savings here, and it really helps build the business case as such. The paper doesn't give as much clinical data in terms of outcomes and safety data, but this, from what it sets out to do, I think it does very clearly, and is really quite encouraging in terms of in terms of demonstrating the savings involved in introducing this service. And I think we've over the years we've all used different energy modalities to manage superficial cancers in the right patients in the outpatient settings, be it diaphragm, be it other forms of laser. And I think that there seems to be some growing evidence and encouraging data regarding the dual diode laser. And I really like this paper. I don't know what you think, Ronnie.
No, I agree, and we've done the same thing actually. We've invested in one of these mobile kind of laser machines, diodes, for use in our treatment centre. So I was very interested by this paper and Tula. You're right, it wasn't so much an outcomes-based study, it was more kind of the financial cost model, which I was surprised. I guess they're coming up with 40% of TURBTs potentially are suitable for this model, which is excellent, more than I thought at first. And the analysis of financial benefits through the tariff for CCGs, bed days and costs. I mean, some of the numbers, I think they said that they reduced bed stay by 1,600 in the recording, but I think it was 760 on the actual table. But still, that amounts to £352,000 savings. Theatre capacity increased 1.4 million, obviously the cost of theatre usage per hour for TURBT was £940 versus £108 for Tula. So as you mentioned, in the COVID year, this is excellent. So more to come from these guys, I would have thought. But it's certainly
absolutely
something that
and I agree. It's very much we need to see those clinical outcomes. It's about case selection, isn't it? And it's making sure that those patients with the high risk disease are well recognised and not undertreated. But it looks like a really nice model, a nice alternative for these patients.
Yes.
So that absolutely concludes the 12 posters.
Yeah. Well, thank you. Yeah, thank you all for your time. Thank you. A very high standard. I was very impressed, John. Also, the hunger for quality improvement and governance is still very much alive amongst our trainees around the country. So that bodes well for the future of BAUS. So thanks once again to them, and thanks to all the viewers for watching this.